Well, the topic that I'm going to talk about is, can epidemiology and individual history help us understand bladder pain syndrome? And the question really is, let me see if I can get this. Have we come full circle? In 1915, Hunter described a peculiar form of bladder ulceration whose diagnosis depends ultimately on its resistance to all ordinary forms of treatment in patients with frequency and bladder symptoms. In 1978, Messing and Stamey took another tact. They said the disease is really nonspecific and highly subjective symptoms of around-the-clock frequency, urgency, and pain, somewhat relieved by voiding when associated with glomerulations upon bladder distension under anesthesia. So it became a diagnosis of exclusion rather than a diagnosis made by the finding of a Hunter lesion. In 2008, Essek defined this syndrome as chronic pelvic pain, pressure, or discomfort perceived to be related to the urinary bladder, accompanied by at least one other urinary symptom, such as persistent urge to void or frequency. Infusible diseases as the cause of the symptoms must be excluded, and rather than call it interstitial cystitis, they term this bladder pain syndrome. The East Asian guideline and the Japanese guidelines, which Dr. Homo was very important in organizing, described interstitial cystitis as a disease of the urinary bladder diagnosed by three conditions: lower urinary tract symptoms, Hunter lesion or mucosal bleeding after distension, and exclusion of confusible diseases. The characteristic symptom complex, hypersensitive bladder syndrome, includes bladder hypersensitivity, usually associated with urinary frequency, with or without bladder pain. But this is the broader concept, and within this, interstitial cystitis is as described, and similar to the NIDDK guideline. So basically, we've gone from 1915, where a Hunter lesion was critical for making a diagnosis of interstitial cystitis, to 1978, when you needed to have symptoms and glomerulations at a minimum, and you could also have a Hunter lesion, and that was also called interstitial cystitis, to 2011, when you could have totally normal findings on endoscopy and have bladder pain syndrome, to 2016, when we're talking about Hunter lesion once again and saying, is this a phenotype of bladder pain syndrome, or in reality, is this a whole different disease? Is this the original interstitial cystitis, and should this be considered separately as a disease and drop out of the bladder pain syndrome category? So basically, it appears now that glomerulations, which we used to really find to be extremely important in making the diagnosis, may have no relationship to the diagnosis and be unimportant clinically. And at any rate, there's a paper that was supposed to come up by Wenovic and Jane Malink, who's here, reviewing all of the literature on glomerulations. It was recently published in the Journal of Urology in January, and the finding was that they have no clinical importance in terms of diagnosis or treatment, and probably should be dropped. So let's look at phenotypes for a second. Regardless of what we call it or how we define it, phenotyping may hold the key to improving treatment outcomes and facilitating research. The only proven phenotype in 2016 is the Hunter lesion, which defined the disease 100 years ago, and as I suggested, may in reality be the disease, be a whole different entity than bladder pain syndrome, and perhaps should be considered that way. There are few, if any, documented examples of a non-Hunter lesion patient assuming the Hunter lesion phenotype. The pathology and the visual appearance is virtually diagnostic. The patient population seems to be different than the non-Hunter patients. And the response to fulguration, excision, steroid injection, and cyclosporin is characteristic. So what should a phenotype actually do? We don't want to just adopt a lot of unproven phenotypes in a clinical setting, because this does not help us unless we know adopting the phenotype helps the patient. Proving the utility of a phenotype is a critical step. The term phenotype refers to the observable physical characteristics or properties of an organism, and these include the organism's appearance, development, and behavior. To be useful when referring to a disease, it could improve the diagnosis, the prognosis, selection of therapy, help us to prevent the disease, improve pharmaceutical research, and perhaps suggest new treatment pathways. For a symptomatic syndrome, ultimately a phenotype could prove to be a self-contained disease and fall out of the syndrome entirely, as we've talked about for Hunter Lesion. Now, how might the patient history in those without confusable diseases help us? Well, these are all potential phenotypes that we may want to see whether they're worthwhile using. We really don't know at this point, but age at onset, acute versus subacute versus gradual onset, the degree of symptomatology, the predominance of pain versus frequency, the precipitating factors, the patterns of flares and remissions, the response to locally targeted therapy versus centrally mediated therapy versus systemic therapy, whether there's a family history of bladder pain syndrome, the relationship of the onset and flares to life stresses, associated pain syndromes, and you may think of others, but these are some of the things that I think we need to figure out whether they're worthwhile categorizing in these patients, and they would help us in the future. Epidemiologic clues to local or systemic disease may also be helpful, and the question is obvious here: are we looking at the same disease in Asia as we are in Europe and North America? The prevalence data is quite interesting. The most recent studies from the RAND Corporation in the United States show that 2,700 per 100,000 women have symptoms that would be compatible with the diagnosis of bladder pain syndrome, and 1,900 per 100,000 men do. Now, most of these people have never seen a physician for this, and it doesn't mean they all have the disease, but it means that it's much more prevalent potentially than we had thought. Prior to this, when using O'Leary's Sant criteria for prevalence, no matter where in the world you looked, you got a figure of about 1 to 200 per 100,000, which sort of intuitively makes a lot more sense than the data from the RAND Corporation. So is there an epidemic of bladder pain syndrome? Well, this recent survey from Japan that Dr. Homo was involved with suggests that the prevalence in Japan when surveying medical institutions in 2015 was only 3.5 per 100,000. Compare that to 2,700 per 100,000. Now, 45% of these patients had Hunter lesions, 38% had glomerulations, and if you look at the graph on the right, you'll see that it really depends on where you were evaluated whether or not you had a Hunter lesion. The majority of institutions rarely, if ever, saw a Hunter lesion, and then a few institutions almost always saw one. So you would think that those bars should be about the same level no matter where you were. But there's probably not an epidemic, and I think the RAND figures are too high, and this figure in Japan may actually be too low. Also looking at epidemiology, can the examination of the number and interaction of non-bladder syndromes give clues to the pathogenesis of bladder pain syndrome or interstitial cystitis? This is work from Jack Warren at the University of Maryland, and he looked at 312 female ICBPS patients and age-matched controls and compared them for 11 non-bladder syndromes diagnosed prior to BPS and calculated the odds ratio and the number of non-bladder syndromes, and this is what he found. The more non-bladder syndromes someone has, the higher the odds ratio that they will have a diagnosis of bladder pain syndrome. You can see if you have 3 or more non-bladder pain syndromes, the odds ratio is 5.1 versus controls. If you have 6 or more, it's 12 times controls. He concluded that syndromes with increased odds ratio of BPS included irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome, depression, panic disorder, migraine, Zika syndrome, asthma, and allergy. And the risk increased with increasing numbers of antecedent non-bladder syndromes. So the hypothesis was either one non-bladder syndrome could promote another, or each non-bladder syndrome has a unique pathogenesis and a second pathogenesis that's common to all of them, causing the increased risk of each syndrome. The risk of BPS was unchanged by the type of non-bladder syndrome present. The odds ratios were between 2 and 3, no matter what the non-bladder pain syndrome was. So we have a lot of associated disorders with bladder pain syndrome that are very important to look at when we're going to look at phenotyping and what may be going on, whether this is a bladder-centric disease or something more. This was a very interesting paper from Eunice in rheumatology literature on central sensitization and chronic sensitization syndromes. And he looked at all of these different disorders that can be attributed to central sensitization and ultimately result in central sensitization syndrome. And certainly bladder pain syndrome could be one of these. There's a lot of overlap, and postulated that any type of trauma, genetic predisposition, poor sleep, infection, inflammation, neonatal or childhood trauma, psychological stress, environmental noise, chemicals, other things can cause neuroendocrine immune dysfunction resulting in hyperexcitement of the central neurons, central sensitization, and this can result in CSS, central sensitization syndrome, and that may be bidirectional. Central sensitization syndrome may result in further central sensitization. This is all theory, but it's very interesting when we're looking at BPS. So what are the potentially possible useful phenotypes of BPS? Hunter lesion is most likely the original interstitial cystitis and a separate and easily identifiable disease localized to the bladder, but subject to central sensitization if not adequately treated, and responsive also to analgesic therapies as well as lesion-directed therapy. Then there could be the patients who have an absence of bladder inflammation, localized symptoms, and no associated disease. Then there's a group of absence of bladder inflammation, diffuse symptoms, and the presence of non-bladder syndromes. There's another group, chronic non-localized bladder inflammation. Another group with a natural history of progressive symptomatology. Another with a natural history of stable or improving symptomatology over time. And then yet another group that you could postulate based on bladder capacity under anesthesia. So these are potentially possible useful phenotypes. The one phenotype that's obvious at this time in 2016 is the Hunter lesion, and I would propose that that could easily be considered a disease on its own, the original interstitial cystitis, and then we could move on from there and drop interstitial cystitis from the category of bladder pain syndromes and give it its own identity. So perhaps an international patient registry would help us find answers to a lot of these questions. Thank you.
Thank you, Philip.